Hi everyone, this is Denise Waterfield. I am here today to talk a little bit about neuromuscular blocking agents, also known as paralytics. Laura McDermott and I have put this information together for our ICU team, and hopefully you will find it helpful. The development of paralytics as a medication started around the 16th century when European explorers found that South American natives were using an arrow poison when they were hunting. It caused paralysis in the animals, and they found that this poison is from a plant toxin called curare. You'll notice that the first syllable of curare is cure, or C-U-R, and you'll see this in the middle of a lot of these medications like vecuronium and rocuronium. Here's a really quick review of the physiology at the neuromuscular junction. So remember that the action potential comes down the neuron. At the end of the neuron, there's a release of the chemical or the neurotransmitter, in this case acetylcholine. That acetylcholine then travels across that synapse or the junction, and it's received on the other side by the acetylcholine receptor. That opens up some ion channels and initiates depolarization of the muscle fiber so that that action potential can go down the muscle and cause contraction. So that brings us to the actual medications. All of the neuromuscular blocking agents interfere with transmission at that neuromuscular junction in one way or another. They do, however, lack central nervous system activity. So we're only talking about peripheral nervous system with these agents. These medications are used quite frequently during general anesthesia to optimize surgical conditions and also to facilitate endotracheal intubation. For the purposes today, we're going to focus more on longer-term use to ensure adequate ventilation. The first group are the depolarizing neuromuscular blocking agents. That includes succinylcholine. This drug will attach and bind to the same point on the neuromuscular junction that acetylcholine does. However, acetylcholine will let go and be broken down by acetylcholinesterase, but succinylcholine doesn't let go. This results in opening up the ion channels, and it allows for rapid depolarization, and it continues to depolarize. This can cause muscle fasciculations and also hyperkalemia. So not ideal long-term, but really good for rapid sequence intubation. Except for succinylcholine, every other neuromuscular blocking agent that's used in the United States is a non-depolarizing agent. So that includes things like VEC and ROC and Nimbex. These medications are competitive antagonists of the acetylcholine receptors. When you initiate these medications, you'll see that they act on the muscles of the eyes and face first, then the limbs and trunk, and then your breathing muscles that are the intercostal muscles and the diaphragm. They have a slower onset but a longer action than succinylcholine. Succinylcholine will have onset of 30 to 60 seconds, lasts for about 4 to 6 minutes. The non-depolarizing drugs, they have an onset of 4 to 6 minutes and duration of about 2 to 3 hours. Both are excreted in the urine and metabolized by the tissues. Prior to starting your NMDA, you want to ensure adequate ventilation, pain control, and sedation. While it's infusing, you need to monitor with a peripheral nerve stimulator like Train of 4, and also monitor sedation with something like a BIS monitor. While this medication's infusing, you want to make sure there's VTE prophylaxis, that there's scheduled eye lubrication. You need to help your patient with passive range of motion exercises, and you also need to assess and protect the pressure points. Train of 4 is the peripheral nerve stimulator that we use in our hospital. The 4 just refers to the sequence of 4 stimuli that's given to a muscle group. These patients need to have their muscles relaxed so that they can effectively ventilate, but they don't need to be too relaxed because that can cause muscle atrophy. This graphic shows that if you have a Train of 4 stimulation on a person that doesn't have a paralytic, you have 4 equal contractions of the muscle group. With the non-depolarizing agent on board, you have this fade in the contractions. It's really important to get a baseline before starting a paralytic on your patient because everyone's different. After that, you're going to use the specific goal for that patient as far as how many twitches result from the Train of 4 stimulator. Remember that these medications are blocking the acetylcholine receptors. It has been determined that if you see one twitch, that means 90% of those receptors are blocked. 2 twitches is 80% and 3 twitches is 75%. Typically, we'll have a goal for a patient to see 2 twitches each time. It's very, very important that we monitor sedation when someone's on a paralytic because we don't want them to realize that they're paralyzed. We do this by the BIS monitor or bispectral index monitoring. This gives us a range of sedation or awakeness of a patient between 0 and 100. If a patient's BIS value is less than 70, then they're more likely to have decreased recall of the experience. Usually we have a goal of between 40 to 60 that allows for adequate sedation but also optimal recovery process. Typically, if a patient stays at a BIS value less than 40 for an extended amount of time, that's associated with negative outcomes, but sometimes it's necessary for the patient, such as someone with a traumatic brain injury, and in that case, we will measure the burst suppression ratio. There's a lot of good information on a BIS monitor. The first thing is the BIS value itself, which is a processed EEG value. Also, there's the EMG, which shows you muscle activity or artifact to consider. The SR is a percentage of the EEG suppression over a 63-second time period. That ST number is the cumulative time the patient has spent in the suppressed state. And then there's also the sensor check, which is a handy device that tells you how well your sensors are working. And then the SQI is the sensor quality index that's usually documented as well. While your patient has BIS monitoring, you want to make sure that you are collaborating with the practitioner to establish the goals. You want to clean that site really well and let it dry before you put those sensors on. As always, treat pain. You want to assess the skin condition at that site frequently and change those sensors every 24 hours or as needed. There are several things you would want to communicate to your provider, including if the patient is not progressing toward the goal or the BIS value that was set. If there's any decrease in the EEG amplitude that you can see on the monitor, or if the BIS value is inconsistent with medication therapy. Thank you for taking the time to watch this video. Remember, you have access to things like Train4 and BIS monitoring on the intranet through Elsevier Skills. Now's the time to have a conversation, to read a little bit more about this or have a discussion here on Facebook, but I know you're busy, so thanks for listening.